So our final speaker is talking today about kind of some of the challenges and the opportunities from partnership working and cross-sector working between the health sector and the leisure provider, something that's very close to my heart, I have to say, with the work that we're doing in Greater Manchester. I harp on again, but it's where I come from and I'm very proud of it. So delighted to welcome you, Andrew Boyd, Clinical Champion for PHE. Thank you.
Hi everyone. Yes, I am Andrew Boyd, and I do work for PHE, but actually today I've got my Royal College of GP hat on, so that somehow slipped through the net. But I'm the physical activity and lifestyle champion for the Royal College of GPs, and that's mainly what I'm talking about today. Although PHE will slip in there a bit because they're doing some great work. The last, Jane, that your project sounds absolutely amazing. I'd just be really interested to know how many GPs were referring into that, if that's the right sort of term to use, and how many of them locally knew about it. Yeah, 0. I think you'd probably say that. So today I'll be talking a little bit about physical inactivity as a risk factor, because we think about risk factors in medicine, and a little bit about the barriers and some solutions and what we're doing at the RCGP to try and get GPs more empowered and more activated to talk to their patients about being physically active. The other thing I'd just say is that it's really great that to a sports conference you're inviting, that Y Sports have invited healthcare professionals, and that it's being held here at the Royal Society of Medicine. I mean, that's a real success story in itself. There's a burgeoning number of GPs and other healthcare providers who are really interested and really into lifestyle medicine, to coin a terrible phrase, and physical activity in particular. And it's really good to see some of those boundaries and some of those barriers already being broken down. So that's something really to celebrate, but we're not quite there yet. So inactivity in the UK population, I'll whip through this because Mike talked about it a bit, but we're very much using the CMO guidance so that everyone's singing from the same hymn sheet about this, which, as Mike said, is 150 minutes a week of moderate intensity activity. And as Mike said, about 40% of the UK adult population are not reaching that. And of that, about 25% of the total are considered inactive, which means that they're getting less than 30 minutes of physical activity in the course of a week. Why does that matter? Well, it matters because physical inactivity is rapidly becoming one of the top 2 or 3 potentially modifiable risk factors for the non-communicable diseases that we see in our surgeries every single day. Diabetes, heart disease, mental health, dementia, many cancers actually, the rates of which are hugely bumped up by being physically inactive, or to put the positive spin on it, can be reduced by being physically active. Although 25% sounds like, well, maybe it's not so much, the people that we're talking about here who, as have already been mentioned in the previous speakers, are the disenfranchised, the poorer, black and ethnic minorities, are massively overrepresented in our surgeries, and therefore, in a sense, we as GPs are in a very powerful position to help, but with power comes responsibility, and I think thus far we've not really done enough to push the physical activity agenda as a profession. And soberingly enough, the UK is more inactive than, Holland, of course, but USA and Australia and France. It's kind of a bit of a shock, really, and it's really important that we're part of the movement to get the country more active. So just considering working as a GP, which is what I do most of the time, a full-time GP will slightly eye-wateringly do 6,000 consultations with patients every year, and that means seeing about 2,000 individual patients. So there's 6,000 opportunities, plus phone calls and all the rest of it, to talk about physical activity, but it's not happening that much. And because inactive patients, because people who have got multiple conditions like diabetes and hypertension and osteoarthritis, etc., are more likely to be inactive. Probably around half of the patient contacts we have are with people who are inactive or very inactive. As a profession, we're still trusted, unfortunately, despite the media bashing that happens, and therefore we should really be in that prime position to be able to say to someone who's come to see us about something that's not quite right with their health, that actually for a lot of them, being a bit more active is really, really relevant. And we're spending our lives battling the conditions that I've mentioned. The other stat I'll just put in there is that we as GPs, and I really cringe at this, sign 1 billion scripts a year. That's 2,000 every minute. And that's because that's what we've been trained to do. We're good at that. We kind of make the link between condition and a drug, and there's a huge pharmaceutical industry that's driving that, and we're trained to do that. What we're not trained to do is to talk about physical activity with our patients, although that is gradually changing, and medical school curriculums, and indeed the Royal College of GP curriculum is going to include something on physical activity in most cases in the coming years, but obviously I'd say not quite enough. Before we move away from risk factors, I like to compare physical inactivity to smoking. Between the 1970s, when smoking reached its peak and almost half the population were smoking, and now there's been a drop from, pretty impressive drop from 45% to 17% smokers. It's not quite there, but it's much, much, much better. And we're running at about 40%, as we said, when it comes to physical inactivity. How has this come about? Through taxation, through national campaigns, through a multi-system approach. And when it comes to us as healthcare providers, we've been incentivised to talk to our patients, to refer our patients, and to reduce smoking levels for quite a few years now. So it's really embedded in our practice, and therefore we've become quite comfortable about it. Behaviour change amongst the population takes time, but it also takes time amongst professionals, including healthcare professionals. And the other thing, of course, is that we've got really clear referral pathways for smoking. We've known, that if we have a smoker, we can offer them these sort of suite of options, and they can choose one. It's kind of quite comfortable conversation. Why does the same not exist for inactivity, which, as I've said, is approaching the importance of smoking when it comes to ill health in the country? So, when the Royal College of GPs, which represents GPs around the country, all 70,000 of us, opted to bring in physical activity and lifestyle as a clinical priority, again, that was something to really celebrate, because we're the first college that have done that, have actually said, okay, this is a big enough problem that basically they have about 3 conditions every year that they prioritise for a period of 3 years, and this is the first time that a college has done that. The first thing that we did when we started working, me and my small team, was to do a survey of GPs. And we wanted to know about why GPs weren't talking to their patients about physical activity. And the 4 main hurdles that I've put here are that they lacked the knowledge around physical activity and ill health. So there was some GPs knew more than others, but basically they knew about the kind of big hitters like cardiovascular disease and diabetes, but perhaps not how important physical activity was in terms of combating it, and certainly not how important it is when it comes to combating cancers and dementia and osteoarthritis, which of course classically is associated with doing less rather than doing more. And there were a lot of myths out there that GPs and their colleagues could be busting, but they weren't because they didn't know the science. They lacked local knowledge. So when I talk about that, I'm saying about local services to which they can refer. Even if they started that conversation, when a patient said, right, yeah, doc, okay, I'm ready to make some change, they didn't really know who to refer to beyond the classic NHS referral, exercise on referral pathways that have met with only moderate success. They talked about fear of offending patients and also coming across as hypocrites, because we know that GPs actually and their staff are no more active than average, and therefore you can't be banging on about being more physically active if you've just driven to work in your SUV, as I keep reminding my colleagues. And finally, and I should have put this in font size sort of 82, time. We really don't have the time to talk in a meaningful way about taking a patient who's less motivated through the whole process of the ambivalence they might be experiencing, what's important to them in their lives, and then finding something that they can do. If I'm talking to someone who's already kind of teetering on the edge of changing their behaviour, that's fine. Sowing that seed is important. And in fact, sowing that seed is important for other people, but we don't always have the time, we often don't have the time to hold their hand through the journey of behaviour change that takes time. So, solutions. With my PHE hat on, Public Health England have really taken this issue by the scruff of the neck, and through their Moving Professionals programme, we've taught thousands of doctors and nurses and allied healthcare professionals around the country about the benefits of physical activity, about how it can be effectively introduced into short consultations with a brief interventions approach. And that's being rolled out in increasing waves across the country, supported by Sport England. As far as disease-specific conditions goes, we're developing a toolkit which is going to sit within the RCGP Toolkit, which is looked at by thousands of GPs every week, that's got information on the benefits of physical activity for specific conditions. So it means that when a patient comes in, patients very rarely come in saying, I want to get more active. They say, my osteoarthritis is playing up, my diabetes is out of control, whatever it is. And we're providing information which is digestible but detailed enough so that GPs can have a useful conversation with a patient about that. We're putting together a database of national, because the website's a national service applicable to GPs across the country, we're putting together a list of options that GPs and their teams can refer into for providing physical activity, and we're working with Parkrun, with Walking for Health, with UK Active, amongst others, to put that in place. I think what we won't be doing, and I think this is going to come up again this afternoon, is offering a kind of referral for all physical activity options in an area, because that's something that's been a very, very hard nut to crack. But at least providing some national options there that are free at the point of service will allow my colleagues to move away from simply offering the exercise on referral that's available on the NHS and nothing else. The time thing. So yeah, I put there perhaps recruiting 10,000 more GPs as a solution for that. But I think we all know that that's not realistic. And actually, I would question whether we're best placed and best trained, and whether it's a good use of our time to be spending the length of time that it takes to really engender behaviour change in the more difficult to change sort of patients. Briefly, why GPs are often sort of closed shops. They do feel, if you're thinking of approaching your local GP surgery, there is a feeling that we're under siege. Now, I shy away from that a bit, but that's how a lot of GPs feel. I don't know if any of you have approached your local surgeries to try and work with them, but that's often the kickback. They're old school organisations. You have to understand that they're businesses run by people who are trained to do medicine, and therefore they have a wariness of the public sector, of the private sector, and even third sector organisations. So just bear that in mind if you're thinking of approaching them. And also there is this kind of persisting, but probably kind of incorrect assumption that if you recommend something and to a rogue physical activity provider, then you could get sued, which has never actually happened to my knowledge. But again, that's a cited reason why GPs are uncomfortable about referring for physical activity options. But I guess there is something about the quality control there, so just bear that in mind. However, there is a really big movement in areas of the country, in pockets of the country, where GPs have taken this and really run with it. And some examples are listed up here on the slide. St Austell, Stuart Smith and his colleagues there have paid for community navigators that offer physical activity as well as other options to patients that are based in the surgery. And that's such an important thing. If you can say to a patient, go and see, I've forgotten her name now, Hayley, down the corridor, she'll be able to talk to you about what options there are in the community to get you more active, to get you more engaged, to get you more involved. And they've seen 50% reduction in their GP appointments as a result. So that thing about workload, if it's done well, it can have huge benefits for GP workload. And that's one of the things we're wanting to share these case studies with our colleagues so that they can see it can be done. Pennygate Medical Centre Gym has been running now for 10 years, and they've got a gym within their surgery, and they've seen reductions in hypertension in return visits from patients who have been engaged with that, and that's been running for a long time. But it doesn't even have to be that complicated. There's a doctor in Southport who was a parkrun advocate, and he started talking to his patients about it, a chap called Simon Tobin, I think. And he's now got, I think, hundreds of his patients now doing parkrun on a weekly basis with him, and he's seen anecdotally reductions in the amount of medication they need for hypertension, the amount of medication they need for their diabetes, and as well as their weights going down and their well-being going up. So it doesn't have to be a bespoke state-of-the-art facility put in place. It can be something really quite simple. And there's loads of examples of Walking for Health, which are based from surgeries. And really, one of the jobs we see at the RCGP is a role to share those case studies with our colleagues. I couldn't not mention social prescribing because it really is the zeitgeist term of the moment, and it really fits in with what I alluded to earlier, which is that we do believe as the college that GPs should be doing something, and they have to sow that seed because they are so well placed, but they can't do everything. Social prescribing, there's a whole hour and a bit talk about that I could do aside from that, but really it's about prescribing non-medical things. You know, I talked about how many prescriptions we're writing. If we could just prescribe something that wasn't a medication, that would often be much more relevant for a lot of our patients. It really, for it to work, and when it's worked well, it really requires someone who has an in-depth knowledge of local services, and I don't think it's practical or cost-effective for that to be the GP. The good news is that funding for this has come online very recently from NHS England, and there will be community navigators, link workers, whatever you want to call it, in the places that you guys are working, so do get in touch with them. I'm getting the nod that I should be winding up. What can you guys do? Well, I think GPs, as I say, they are getting the picture slowly. So if you are a physical activity provider, go and show your face at your local practices. Ask if there's a local Public Health England champion, because we are scattered around the country teaching groups of GPs, and they also have an advocacy role within their community. So I'll give you the contact details for that in a sec. Find out whether you have or are going to get a community navigator, because they're the real people that you want to engage with if you want to pick up some of the patients that we're seeing that would actually be better seen by physical activity providers. Talk to someone else in the practice rather than necessarily the GP. Often the manager or the reception lead is a much better placed person to have a chat to. Most practices have a patient participation group, and again, as patients get more on board with this agenda, then they're good people to speak to. And tell them about your service and how it can link to reduced workload. Finally, very surprisingly, when we quizzed GPs, they said they were very happy to be offered incentives for local opportunities as long as it was available to other members of their team and potentially to patients as well. So do try incentivising. That's all from me, really. If you want to talk about the RCGP initiative around getting practices more active, then please drop me a line at that email address. If you're interested in the Physical Activity Clinical Champions teaching programme, which is being rolled out around the country, then that's the email address. And there's also a link to the British Society of Lifestyle Medicine, which just demonstrates how much of a following there is amongst my profession. Thank you.